Okay, let me ask you, how would you treat what you're about to see? This person has knee pain, all right, and some what appears to be a strength deficit. What would your choice of action be? Watch what he cannot do.
Go ahead and show us the hard side. So he's at 70 pounds, and there's just nothing, okay? Show us the good side. And again, no problem. And
So typically, the response would be he's got a problem in the knee, maybe he's got a strength deficit. You might lessen the weight, see if he can do it in a shorter range. You might look at the knee, do some knee mobilizations. You might go up into the hip, right? So we would stay where? Because what I'm trying to show is this pattern and this cultural bias and professional bias we have when somebody walks in with an injury. So obviously we're going to sit there and that's what we're going to focus on is the region of injury. We'll watch what happens in this video.
now he's going to go do a couple sets, and we'll come back and show you the result.
So we made him do stuff on his good side. And so we made him do, I think, 3 sets of 10 to 12 on it. I'm going to say it in a second. And watch what happens on his right side.
Okay, we actually did 3 sets. He didn't do 70 pounds with a good, he did 55, then he lowered to 40, and he went to 25. So it's not about weight, it's about motion. And we were going fast, and sometimes we're going slower. So go ahead and check it out. Ta-da!
Okay, cool. Okay, so let me show you another progression, another person, and let's ask you how you would treat them.
All right, bend forward, sliding your hands down until it really bothers you. Don't move further than what your body wants to. That right there, you're gonna grunt and stuff. Come on back up. That's sometimes when it gets you.
All right, so again, this is my basement. A buddy came over. This is my workout and my filming studio area, and so he couldn't bend forward. Woke up that morning, boom, couldn't function. So again, no injury, no surgery. What and where would you start with him? All right, we're going to show you that we're going to start with a twist going to the yummy direction of motion. And we're going to see what changes.
So he loves right rotation. Just going to take it and see what happens. All right, after 3 sets, boom, almost his toes, good. Back up, do that again. So he's done some twisting to the right with pushing in the end range. Come back up.
All right, again, I'm trying to get you into a couple of things. Recognizing that, whoa, doing this good-sided stuff seems odd to you, which means it's not something that you would normally look at or be presented with, right? Or think, it's a blind spot in your treatment. All right, so let me show you a couple more, because initially what happens when I'm showing these, you're going to get some gut responses of, oh, well, that's because this. I don't know enough about them, or maybe I would do it that way. All right, so let me just show you. By the time I show you about 7 of these, you really get into this idea like, oh my gosh, I don't know this. Wait a second, what is this crazy thing about not doing the area of injury is fixing the area of injury? So here's a spine surgeon with this presentation. What would you do for him? And then let's find out what we do for him.
Do extension for me. That's it. Wow. All right, and now go ahead and flex forward, which he's pretty good about that.
So again, traditionally, what would you do for somebody that presented with that type of inability to extend? Let me then go show you what we do to help fix them. So what you're going to see here is that we're actually going to take him to an arm exercise, which actually is also a spine exercise because he's going to do it one arm, and check out to see what happens. Now the noise, if we start hearing noise in the middle, this is a compression machine. These are Kaiser equipment, so they use air resistance.
Find difference one at a time too.
So he's very weak on the left side, so he's going to use his right good side to do this.
Right, it's harder. Okay, left is harder. This is actually a spine surgeon who's had an MRI, and he's got, what's all wrong? Just say it louder. What's wrong with you?
I have 3-level degenerative disc disease with severe tightness at the L3-4 level, L4-5 level, and the L5-S1 level, with the L4-5 level being the worst.
So he's going to exercise for 4 sets.
Okay, go ahead and push that left one now, see whether you can do it. Nice and easy. Now go ahead and stand up. And come on back over by this machine. Same place we were. Turn. There you go. Now go ahead and extend backwards. Look at that. From a chest press.
All right, so again, what ends up happening is there are a lot of, like I said, I can show about 70 of these videos, and all of a sudden, initially, skepticism. And that's healthy. That's what should come in. I keep showing them, and you realize, oh my gosh, this is not something usual that I would use or that I've seen, and wow, maybe this could help my issue, or maybe this could help, if you're a therapist, my patients that haven't gotten better. And I'm trying to show you there's a lot more solutions than you are known to, or than you know about, simply because you keep staying in the area or the region of injury. So if somebody had a shoulder issue, you're staying in the shoulder, the arm, the neck, the thoracic, and the ribs. I want you to look elsewhere. If you don't know that a left leg can fix a right shoulder, you're missing a huge component of treatment. Okay, on this person here, this is a physical therapist, 8 months post an auto accident, nobody can figure out how to help her with this very weird eye presentation, but you're going to notice she's got a lot more going on just her eye presentation. And again, what I'm going to choose to treat it with, most likely you're not even going to think of, right? So right now I'm just going to ask you, we're going to stop it, and I'm going to ask you, what will you treat this person with?
It's much harder. Just trying to see if you could notice a difference when I go up. This is up and to the left.
Yeah. I mean, it's funny because even your pen movement of in your hand. Okay, cool.
So they blink a lot. I don't know what that is, but I think it's just because they're struggling so much to go that direction.
Interesting. Okay, so right up like that. All right.
So this is left. I can touch the floor.
Okay.
And this is right.
Oh.
Flexion is fine, but extension is, there's a huge pull at the end range of extension. I don't even know if it's the end range.
Okay.
So extension is harder.
Look how horrible that is.
Low, medium, or high? Low, medium,
high. High.
Oh, okay, sorry. The treatment came on, but nobody would typically, everybody would look at that and say, wow, I've got to stay up in the neck. I got to do neck. You think that that's the fastest way to treat somebody, right? Staying in the area of injury. Well, she's had 8 months of treatment. She's a physical therapist herself. They've done ad nauseum on that area, and nobody's changing her. So we go and scan her whole body with a total motion release scan, and we find that she's got some leg issues on a bad side and the good side on the other. And then we have her do some sit to stands.
Low, medium, or high?
Okay, so she's going to treat some sit to stands.
So I should do them not holding up.
Again, it's just gonna
hold on to anything. There's nothing wrong with it, okay? But initially, if your body can do it, and again, you don't have to turn to the side. You can have the chair.
I'm just going to fast forward this a little bit. Okay, so here's her retesting. This is the first time. There's going to be another glitch. Like, it looks like a glitch because I forgot to film the treatment. And then she's going to reassess herself twice here. I'll probably just go after the first one because you'll see the huge improvements, and that's the point that I'm trying to make.
Look at your eye motion to the right. Okay, so take your pen, or you can just do it on your own. It doesn't really matter to me. Well, it helps me see because of your hand. All right? And that was at 60. Let's see what it is now. It's better.
That is much easier.
Yeah, so it was a 60. We're heading to 0. What is it now?
Like 20.
All right. Let's try the lumbar side bend to the right.
Just put the chair straight here.
Awesome. Let's try your neck extension, which was a 90.
So much better.
It was a 90. Come on back. You don't have to. Now you like it. Now you like it back there. It was 90. What is it now?
I feel, again, I hate to give them all the same number, but I feel like 10. I feel like it went almost the whole way, but just a little bit of resistance at the end.
So let's now go recheck. Use your pen, seeing we did.
That's the part that I skipped showing you. And again, we use a scale of 1 to 100. Think of that as a 1 to 10, except a 10 would be 100 on our scale. So if she says she starts at a 90, it's a 9, goes all the way down to a 10. Okay. If she says it's a 5, she means basically it would be a 0.5 on the other scale. So
in the beginning, and use it in the left hand because you actually had it in the left hand before.
Okay.
Yeah, even though you did, and then take it up to the left. It was 16 went to a 20. Oh yeah, look at that now. How is it now?
I'll say I don't know. The only reason I gave it a 5 is because I felt like it was good, except that it was blinking a little bit at the end.
Awesome. Let's try your lumbar side bend. Was it? You gave it a 10.
5.
Neck extension. Give it a 10 before.
I'd give it a 5. It's much.
So there you have it. So how many of you would have gone to a leg to fix what appears to be something in the upper body problem? Not many, right? So I'm hoping you're seeing the blinders that you have had on, both culturally, because again, a patient too, when they come in, is expecting you to treat their leg, somewhere on that right, let's say it's a right knee pain. Okay. So we're going to do 2 more here, get you the big picture of saying, wow, this is fascinating that you're losing out on huge amount of opportunity that you didn't even know about. So this gentleman has got about 4 or 5 shoulder issues.
So if I point my thumb the other way,
Go up to the sky.
yeah.
Okay.
Point my thumb the other way,
Go up to the sky.
yeah.
Good. That's what we want. Those are the things we want right there.
Yeah.
So that is you're externally rotating your arm. The thumb to the sky. We'll tell thumb to. What's that? Low, medium, or high?
So that gets up to high.
The seven,
So 60, 70, 70, yeah.
Low 70. All right. Other motions that you can do to make it. Hand behind the back, so you're trying to scratch your back.
Yeah. So
Stand up and let your back face me. So turn around and let's see your hand behind your back. Good. Now the other one. Good. All right. Low, medium, or high?
yeah, I would say that like 60, 70.
Call that a 60. Good. All right. Anything else? So you see what we're doing. We're analyzing the full body, then we're analyzing the area.
Right, yeah. So
What about something like this?
yeah, so here we go. We'll do this side.
Good. Oh, yeah. Yeah. So we'll call that.
Okay, so there you have it. How would you treat this person with all these shoulder issues? Give you a little backstory. There's no trauma. There's no surgery sitting here. 5 years he's had this. His wife's a physical therapist. Again, have not been able to change it. The reason is they keep going to the region of injury. 98% of the techniques out there are teaching you in the region of injury, which is fine for the region of injury, okay, if it's going to work, right? It's only 2 out of 9 times will the area of injury work faster than using other areas or something that's good in the body. But you don't know that yet, and I'm trying to get the word out there that this is one of the failures when people fail. This is one of the reasons that people are failing treatment is because we're just looking in one area. Watch I believe a twist is what changes him.
Chicken wing out front or something.
Okay. And I would say that's similar to the others in terms of levels. 60, 70, yeah.
2 sets of 20 reps to the trunk twist. I'll probably just watch one of these. You'll see it change a ton.
What I want you to do now is to do your.
Do that first.
It was a 70, went to a 30. Where is it now?
It's 15.
Very good. The other one that we did, what was that? Oh, hand behind the back. Stand up and put your hand behind your back. It was a 60, went to a 20. Where is it now? Pretty good.
Yeah, amazing. Yeah. Yeah, we're 15, 10, 15. Yeah.
Still have something left there?
That would
Yeah,
be
yeah. Uh-huh.
We're not going for
10 or 15 would be on a 1 on the 1 to 10 scale.
right. Even like I tell people, even if you go to 0, it doesn't mean it's perfect necessarily, but it's like really good for the session. But again, 10, I like that. So 60.
If it went to 0, I wouldn't believe myself. So
exactly, I get it. No, people tell me that too. No, I can't do that. So now we're gonna do the chicken wing, but
yeah,
like this, I guess. It was
so. Yeah, this one is
10 to 15. What is it now?
5.
Good.
Good. So you get the idea there, right? So let me now show you, this is a jaw issue. Not only does she have a jaw issue, I think she's got 6 other things too that I'm going to show at the end. I'm not going to show this whole one. We change her presentations of all 7 of these with a leg raise. Now you might be thinking, oh, do you do the legs for the upper body? And there's after you do a scan of the full body, you've got lots of choices. It just happened to be the choice that we did. But here's what all she had wrong with her. She had a headache. It went from a 60 to a 70. Jaw went from a 90 to a 10. Jaw moving to the right was 50 to 15. Biting down was a huge amount of pain. Went to 0. Side bend, neck extension. Sorry, you can't read. The toe touch, 50. I think it was a 50 to 0. Session lasted an hour. Now, a lot of times at this point in time, people will begin thinking, well, hey, but what about if they've got had surgery? What if they've neurological, like they've had a stroke or something like that? Well, again, if you're treating them currently as therapy, then they're in therapy, right? We're just going to move the body and test the full body, and then we're going to go to other areas you haven't used and do those. So this is a stroke patient. This is very quick. I'm just really showing you the befores. We did a twist and a leg raise with this gentleman, and these are the changes. So it's crazy. This is a gentleman 3 months post-stroke. I've got one that's 19 years post-stroke with very similar presentations. We've done this with somebody who is 3 days post-stroke. This person happens to have a elbow contracture or a contracture somewhat too. But again, you watch to see how his flexion and his abduction does.
All right, so what I want you to do is just show us what you can do or what on the raising forward and raising out to the side. Okay, good.
So again, let's take a look at that again. So that's it. His elbow's very bent. Going out to the side, that's it. He does turn, so he's still having difficulty with that. And sorry about the space in between here. Okay, there he goes fully. Look at that. Is that nice? And out to the side, check this one out too. And when he comes back down, you're going to notice his arm.
Yeah, I see that.
He's
Arm's going to get straight out too. Good.
Good. All right. Again, 3 months of treatment. He's been in a bunch of rehab. No changes. The same with the guy that's been out 19 years I told you about. So very big, huge changes. If you want, you're wondering about the research behind it, go to totalmotionrelease.com. Up to the top, it says research. You can check out all the research been done in TMR. Think about this as those of you who know what mirror therapy is, people haven't been using but one quadrant. So like if somebody has an amputee on the left side, they've been holding a mirror up so that it gives them this pseudo left-sidedness, right? And they're squeezing the right side. That mirror can be turned in all axes. So when it's like this, it's left to right opposite. We could have it in the, let's say the shoulder, we could be front to back opposite. We could turn it this way, and now we're top to bottom opposite. And we can do it diagonal, which means diagonal opposite. So the opposite of the left shoulder could be the right leg. So what you're beginning to see is that your way you've been conditioned, the way you've been taught, and your teachers have been taught, and the teachers that are teaching other people have been taught, is to go to the region of injury. All right, and I'm trying to, by demonstration show you, whoa, there's a big picture that's missing, and that's the other quadrants of the body, regions of the body that aren't being used that actually often work faster. Fair enough? All right, so again, totalemotionrelease.com, and check out the other videos that we have, and hopefully you'll be excited by it, and whether you're general public, you'll take a seminar, or whether or take some training, or whether you're a clinician, take the training. It's really, really cool, and you'll be able to treat patients better than you ever have a lot more wins, and also 7 times less failures. So thanks a lot for watching.